Alrighty, welcome back. This will be a part two of Airway. So, lecture number two for Airway. Welcome back. We shall continue through our review, basically, of what we kind of already covered and already kind of know. When we're talking about ventilation, again, this is the process of moving air into and out of the lungs. It's essential, obviously, for life. Without ventilation, there would be no life. Um, we have the part where we're trying, we're getting air entering the body from the outside in through the mouth and the nose, bringing it down using the diaphragm and intercostal muscles to contract. That helps those lungs fill with air, and then the diaphragm relaxes upon exhalation. And we talked about partial pressure. That is a measurement of an amount of gas um, that's in the air, or it could be a measurement of gas maybe being dissolved in a fluid. What we're looking at in inspiration is focusing on that delivery of oxygen to the alveoli. And we need to get it to the alveoli so that we can have a gas exchange. And then we talk about exhalation. Exhalation, important to know that it does not require energy as long as you're breathing normally. Now, if you're in distress and you're like with asthmatics, where a lot of times you get trapped air, you get air in, but it's hard to get air out. You're using energy in that case when you're in distress, but normally does not require energy. It's passive. And so regulation of ventilation. So how do we regulate that? Well, we know that we have the brain for that, and specifically the medulla. And the medulla receives the information, specifically the amount of CO2, carbon dioxide, that's in the blood. And if we have a lot of CO2, we're going to breathe faster to blow it off. If we don't have a lot of CO2, obviously we're going to slow down. The body does not respond initially to oxygen levels. However, we know uh, in that hypoxic drive that over a period of time, high levels of CO2, the body can't read that CO2 anymore and therefore switches to reading oxygen levels. All right, so let's talk about oxygenation. Let's look at that. So, oxygenation is that process, right, of getting oxygen molecules in place to provide to feed the cells. And what I mean in place, I mean we have to be able to get those oxygen from the alveoli into the red blood cell, and it's the hemoglobin that keeps that oxygen molecule in place so that it doesn't fall off, and that we're able to deliver then that oxygen molecule to the cells. When we're talking about atmospheric pressure and high altitudes, um, that does affect um, the amount of oxygen available for us to breathe. And so, therefore, um, it takes a little while to get used to a less amount of oxygen to be available for us. But people live in the Rocky Mountains all the time, and they eventually get used to it, and it doesn't become a problem anymore. But let's think about metabolism, and specifically aerobic and anaerobic, aerobic with oxygen and anaerobic without. Um, we understand the process of exchanging in alveoli. When oxygen leaves alveoli, it goes to the red blood cell. And when carbon dioxide exits the red blood cell and into the alveoli, we call that diffusion. And then there is internal and external respiration. So external respiration is that process of getting fresh air into the respiratory system. Okay, so we're going to be exchanging that, again, oxygen for carbon dioxide between the alveoli and the red blood cell. And when we talk about someone who is having adequate ventilation, doesn't guarantee that we have external respirations, because there's some requirements. We have to have that hemoglobin right there to receive that oxygen to keep it in place inside the red blood cell. And so if we don't have hemoglobin, therefore we may not have the appropriate external respirations that we need. And then we have internal respirations. So internal respirations is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. So when we have oxygen, oxygenated blood is traveling through the arteries and the capillaries, right? It's going to meet up with those tissues from the cells. And that's when we talk about internal respirations. It's that actual feeding those cells that oxygen that we receive during external respiration. So external, think about outside. Think about the 21% oxygen that you got to have to be able to inhale. External. And we get that 21% oxygen down to the alveoli. Then we have internal respiration. And that's once diffusion has occurred and the red blood cell has plenty of oxygen now, it can go to the cells that are internal, the internal cells, and feed them that oxygen. And the same type of diffusion process takes place there too. The O2 will diffuse into the cells and the CO2 will diffuse out of the cells. And that process between external and internal respirations just continues. We know about aerobic metabolism. We know that a lot more now than we did before in EMT school. We know that mitochondria in the cells converts that glucose into the energy that the cell needs. And we know you got to have oxygen for that to happen. Otherwise, it wouldn't be in the mitochondria. Then we have anaerobic metabolism, right? And so what happens there is if there's not enough oxygen inside that cell, then we don't make it to the mitochondria, do we? No, we don't. And if we can't make it into mitochondria, we're not able to get that energy that we need. And so we produce that lactic acid. And so this occurs a lot of times when you're working out. You're working that muscle really hard and it doesn't have time to get the oxygen that it needs. It's burned all of it up. So therefore, you produce lactic acid, and it's that lactic acid that causes that pain. Here so it's another look at they call it the neural control of breathing, right? The nervous system. And so we've covered this quite a bit. We know that these chemoreceptors live here in the arch of the aorta. It reports that information to the medulla, and then the medulla will make plans to do what it has to do based on the readings at the medulla, we have that central chemoreceptors. They read that information, and they read the amount of hydrogen, which is AKA acid. We read carbon dioxide, right? And it actually reads the cerebral spinal fluid. It doesn't matter what it reads, as long as you understand that it reads those things and that the body will adjust based on those readings. For example, if we have a lot of hydrogen ions, we're going to instruct the kidneys to get rid of that hydrogen ions through urine. We're going to increase the respiratory rate to decrease the amount of CO2 that's present. And so, again, this slide just tells you that the medulla, the respiratory center, is in charge. The apneustic center of the pons is going to be the secondary control center if the medulla fails to initiate. So right here below the medulla, here we have the pons. And then we have the pneumotaxic center. And that's known for a inhibitory influence on inspiration. Again, chemoreceptors, we talked about those. We should be pretty familiar with that. And then we talk about hypoxia. And hypoxia really is the lack of oxygen to be able to be delivered to the cells. And we know that there's two ways of this happening. We could be breathing just fine, but secondary to blood loss, we can suffer hypoxia because there's not enough red blood cells there at the alveoli level to show up to be there for that diffusion, right? And then, of course, we know the other one, which is an asthma attack, some type of bronchial constriction, anything that doesn't get that external respiration job done. We don't get we don't get 21% oxygen down to the alveoli to be available for the red blood cells for diffusion. Let's talk about some early signs of hypoxia. This is the patient who could be very restless, right? They're very anxious. They could be tachycardic. They're just very apprehensive. They can't make a decision or extremely irritable. And a lot of that's because the brain itself is becoming hypoxic and it's not, and it's becoming irritable. And therefore, the body shows that through anxiety and, lack of decision-making ability. You're very irritable or restless. Some of the late signs of hypoxia would include a mental status change, somebody with an altered mental status. Maybe they have a weak pulse, or maybe they're cyanotic. Cyanosis, that blue color, is a sign of late hypoxia. We talked about VQ ratio, ventilation to perfusion, right? And so what we're talking about there is the ability to have, on the ventilatory side, to have oxygen readily available for gas exchange at the alveoli. And then we're talking about Q, the blood, having that blood available to be there to pick up the oxygen from the alveoli. So anytime we're hypercapnia or hypercapnic, we have an overall increase in that carbon dioxide level. The things that could cause this, besides respiratory distress, trauma to the head or spinal cord. That trauma to the head might mess with the respiratory center of the brain, the medulla. Muscular dystrophy, bronchial constriction, all of that could be forms of having a factor with ventilation. We can look here at some external factors affecting oxygenation. Attachment of carbon, not dioxide, but monoxide. Remember, those hemoglobin has a real love for carbon monoxide. It was its first love. It left him high and dry, and he's missed her ever since. And when she shows up again, he just wants to hold on to her. And so that's the problem. And Unfortunately, our cells cannot be fed by carbon monoxide, and so therefore, it starts feeding the cells with that, and it's a love-hate relationship. It loves us so much that it hates us and ends up killing us. And let's look at some internal factors that could cause problems with ventilations. About that, a condition that reduces the surface area for gas exchange. And I'm thinking something to do with surfactant. Remember, surfactant is the major player that allows the alveoli to have surface space. How about pneumonia? Right? COPD causing problems in the bronchioles themselves, causing some bronchial constriction, um, or they call it bronchial plugging. That's blocking the bronchioles from getting that air to the alveoli, or non-functional alveoli, like we see with patients with COPD. So we could face circulatory compromise, any type of problem that would cause us to, to lose blood, right? That could lead to inadequate perfusion. Other conditions, pulmonary embolisms, right? That pulmonary embolism is usually, it could be located in the pulmonary artery, and that emboli blocks blood traveling to the alveoli for gas exchange. It gets blocked there, and we're in a hypoxic state. Attention pneumothorax. This is where we've had a problem with either a simple pneumothorax with a blebby, maybe in the lung, and over a period of time, enough pressure builds up to cause the lung to collapse. An open pneumothorax with a similar problem, except there is an opening of bringing air in to the lung. It's usually a little more severe than the simple pneumothorax, right? We have a big air in that pleural space that's causing a major problem with the pressure in that area. Becomes more positive. Then we have a hemothorax or a hemopneumothorax. Hemo meaning blood, right? So not only do we have air in there, but we could see blood in there as well that could cause a problem. And also heart failure, right? Again, if we have so much hydrostatic pressure that we can't pump against, the left ventricle can't pump against, right? Then we'll have a backup of blood. And a backup of blood is, is as bad as no blood at all. Hemorrhagic shock, right? Hypovolemic shock, but we're talking hemorrhagic shock here in this case, a loss of blood loss. And blood loss, we're losing what? We're losing cellular blood. When we lose cellular blood, I'm talking about red blood cells, white blood cells, platelets. Vasodilatory shock. All right. So if our blood vessels vasodilate, like we see in an anaphylactic reaction, we don't necessarily have a blood loss, but we have a blood displacement loss. It's not in the right place. All right. Acid base. We've talked about that. Just a reminder, respiratory acidosis or alkalosis, and metabolic acidosis or alkalosis. So recognizing adequate breathing. We want to recognize an adequate respiratory rate is one of 12 to 20 breaths per minute. All right, but we could have the best respiratory rate in the world, but if we don't have adequate tidal volume, then it doesn't matter, does it? Right? We're going to bag somebody that has inadequate tidal volume with a respiratory rate of 14, right? So, I mean, that's just the way it works. And so the respiratory rate is not the end all be all, but tidal volume is. Also, recognizing adequate breathing means we have clear and equal breath sounds. There's nothing impeding in the lungs when we hear clear and equal breath sounds, nothing impeding that oxygen from reaching the alveoli. So respiratory distress, it could be a result of absolutely of upper or lower airway obstructions, right? And we need to be able to determine the differences in those. Stridor versus wheezing, right? Stridor being an upper airway problem. Inadequate ventilation for whatever reason. We could have a problem with the muscles of the respiratory system, like the diaphragm. If the diaphragm is injured, it's going to cause a problem in ventilations. What about a head injury? A head injury that injures the medulla absolutely could cause a problem and cause us to have distress. Dyspnea, right? AKA difficulty in breathing. Difficulty in that respiratory rate, the regularity of it, or even the effort. All right, and so how are we going to assess a patient as respiratory distress? Well, the first thing we want to look at is what's that patient's position? How are they sitting? If they're laid back in their seat, it's a sign that maybe either they've decompensated or they're not in distress at all, maybe. We see somebody in a tripod position, we know then that's a patient that's more than likely in distress. They're doing everything they can to push use those muscles to expand that chest cavity to allow those lungs to inflate. What about orthopnea? Right? That's something to think about. We should understand that definition. Right? And so we need to think about a certain situation where someone is not having trouble breathing in a sitting position, but maybe they're having trouble breathing in a standing position, or the opposite. Maybe they feel much better when they stand. Is there adequate chest rise and fall? That's the $1,000,000 question, really, because at the end of the day, that's what it comes down to. Are they gasping? What are they doing? We call it fish breathing sometimes. What are they are they doing an effort to increase the expiratory pressure in their lungs? Are they gasping or puffing? What about skin color? So a patient who's not breathing well, you can notice cyanosis, cyanosis around their lips or maybe in their extremities. Nasal flaring, that's always something to look at. We see that a lot of times with children. Oh, there's pursed lips. That's just what I was talking about a second ago. What about any type of muscle retractions? Right, we can look in between the rib cage to see if those accessory muscles are working. Is it symmetrical? Is the chest rise and fall symmetrical, or is one side, the right side, coming up and the left side slow to come up? Is the patient taking a series of quick breaths and then followed by a prolonged exhalation phase? This is kind of a classic of an asthmatic attack where a patient is, taking several short breaths and then really working hard to try to remove that trapped air. Here we have somebody here in the neck. You can see the sternocleidomastoid, the pectoralis major, and the rectus abdominis muscles here. Those are all signs of the patient's really working to breathe. Okay, guys, it's been about 25 minutes. I'm gonna try to keep these lectures at about that 25-minute time frame. Keeps everybody fresh and listening. This will be video lecture number 2, and I will see you soon with video lecture number 3.